I would say that as time goes on, the world changes and what's expected of you changes, and meaning, managed care changes, and the word comes down from.
Hello, eShadowing. Hello. How's everyone doing? I hope you're doing well. Let me bring on our guest. Let's see if I can find them. If you are here, oh, look at that. I was just going to say, raise your hand. And they did. Not all of you. Just our guest for today. I love it. Hello, Lance.
There we go. How are you?
We are here. We did it. Right off the bat, Meyerson or Meyerson? Meyerson. All right. That I love.
I think we gave you the wrong phonetic spelling.
Well, that's what I was confused. Like, I love asking for a phonetic spelling, and then people get pretty crazy with it. I'm like, I don't know. Still, I'm still lost. But we got it. So Dr. Meyerson, otolaryngologist.
Yes.
We're gonna talk about some parts of the head today.
Okay. Don't make it too complex, because I'm a few years out of medical school.
Well, that was my first question: is what innervates? No, just kidding.
Right.
Yeah, I have a neurologist wife. Well, all we talk about is innervation of things. It's like, come on.
You have an interesting life.
Yeah, I did do better than her in anatomy. So that was my one claim to fame. She was AOA. I did better in anatomy.
Very good.
Oh, well. I married the smart one. Well, I'm excited to have you on. Thank you for taking some time to chat with us today, to hopefully help this next generation of students understand what otolaryngology is and why does it have such a complicated name that we just call it ENT. That's the first question.
Let me say thank you for the invitation, and more importantly, thank you for doing this in general. I mean, this is what you're doing is wonderful, and I wish it were around when you and I were their age.
Yeah.
So otolaryngology, short for, actually the field is otorhinolaryngology, head and neck surgery. So otorhinolaryngology, head and neck surgery. And those are basically the four parts of the profession.
Okay.
Ears, nose, throat, and
ears,
head and neck
nose,
surgery.
Throat, head and neck surgery. So what is bread and butter for an ENT surgeon?
So I guess it depends on whether you do pediatrics or adults or both. And I've done all of the above throughout my career. Right now, I just take adult patients. But, in kids, you're seeing children a lot for tubes, tonsils, chronic throat infections, chronic ear infections. That's what kids get. Adults are a little different, and you have varying age groups. In teens, 20s, it's still a lot of infections, sinus infections, throat infections, that sort of thing. And as people get older, you see some patients with cancer, chronic smokers who come in with sore throats. A lot of times they're very scared of what they have. Thyroid conditions, what we call chronic ears, chronic suppurative otitis media, sinusitis, and there's a whole field of rhinology for nasal and sinus conditions. There's laryngology for throat conditions. So there's a lot of different ways that people can go. But bread and butter, probably in adults, a lot of ear problems and nasal and sinus problems probably take the day on that.
Yeah. And is that something that changes over time? Because I mean, to me, if I were a layperson, I'd go, well, my skeleton is my skeleton, my skull is my skull. That doesn't change. What changes that prompts someone to come in to say, okay, there's something new here. I can't breathe, or I can't do this, I can't do that.
A couple of things. Number one, chronicity. I'm sick and tired of going to the doctor and being given antibiotics all the time. What can we do to stop that? And second, a lot of patients are sent in by their spouse. I snore. I'm always complaining. I'm sniffling, blowing my nose all the time. So here I am, to see you to fix that.
Fix me.
Yes.
What do? You do you just go and like cauterize everything inside so they can't produce mucus anymore? That doesn't seem
Well,
healthy.
actually, there is a procedure for that
Yeah.
right now, but you know, I do an assessment, and I do a lot of nasal and sinus. That's my focus. And like I said, I have done everything over the years, but now it's mainly nasal and sinus. And I take a history, do a full exam, scope the patient, and if it's indicated, get a CT scan, and that's kind of my workup for most of these things. And there are a few things that recur over and over. One is allergies. That's probably the number one thing. And I'm fortunate enough to be in a multi-specialty group where we have some great allergists, and we work together, and I mainly do the procedures and they put people on the allergy shots, where many otolaryngologists, particularly in private practice, do their own allergy injections. And I did that for years before I joined this multi-specialty group. So I mainly evaluate to see if people need procedures, most of which are done in the office now, which is a huge benefit to patients over how it used to be years ago.
Yeah. Let's talk about some current events to see how that affects your job, and maybe the need for more otolaryngologists in the future. Climate change, global warming, climate change has become obviously front and center every year. It seems like things are changing and getting different in places. Is that triggering allergies differently now for people in areas where they're like, I've never had allergies before? What's going on?
Well, I'm in Florida, so we're kind of ahead of the curve on that, and we've had that
Yeah.
for a long time, because things don't die here. It
Yep.
really never freezes in Tampa, where I am, and so people have allergies and sinus problems year round. Believe it or not, we actually have a pretty large population that was around on 9/11 in New York who've moved to Florida, and there's actually a big number of those that kind of what you're talking about. They got the sped up version where they were exposed to a lot of dust and things in a short period of time. And I've taken care of those patients for a long time.
Yeah.
So yes, we are seeing some of that.
Yeah, it's very interesting. And then obviously we've been in a pandemic for a couple of years, although luckily Florida wasn't hit, at least according to the news.
You're right, it didn't come to Florida.
It didn't come to Florida.
No.
COVID, how has that impacted the ENT world, if at all?
Well, the ENTs and the ophthalmologists were hit the hardest in China. And we took that as a lesson here. And we were closed down for a little while, as everyone else was. And we didn't do surgeries because, we weren't allowed to do non-essential surgeries for a while.
Yeah.
But I was fortunate enough to be able to get N95 masks early.
Mm-hmm.
And, when I went to work, I always had the N95 mask, and to this day I do as well. I mean, I'm alone in my office here, but we still have a policy in our office that everyone wears a mask in this building. And although based on what the CDC is saying now, the hospital that where I do surgeries is changing that to be in non-patient areas. It's optional.
Wow.
But that's just, I think that's happening this week, in fact. But we still have a policy to wear masks, and I wear an N95 all the time. And believe it or not, I haven't had COVID. I'm gonna knock on wood here.
Knock on wood.
That haven't.
Yeah.
that
Yeah, me
hasn't had
neither.
COVID.
I still never tested positive for it, thankfully.
Yeah.
And when you mention ophthalmologists and ENTs, I'm assuming that's just proximity, similar to the anesthesiologist who were intubating everyone at the beginning. Just you're close to a mouth and a nose and where droplets are coming out.
Precisely.
Okay.
Yeah.
Interesting. Very interesting.
So I didn't scope people for a while, even when I was back in the, in the office. I would say I didn't scope someone unless it was critical, put it that way. So that's 99% of the time, it's not critical to do it. You can do it another time. And I just didn't do it for a while.
Yeah. So the question I think for the people watching right now is like, ooh, what's critical? That's what they want to know.
Well, an airway emergency where somebody has stridor with difficulty breathing, that sort of thing. But if they're here because their nose is congested because they have sinusitis, that sort of thing, that's not critical.
Yeah. Yeah. That's not the ABCs. That's just annoyance. Right. Interesting. Okay. What do you love the most about being an ENT?
I'm glad you asked that question. And I've been asked that question, throughout my career. And when I was in medical school, I wanted to be a surgeon all along. I was going to be a general surgeon. That was my thing. And then I rotated on general surgery and I rotated on ENT as a subspecialty, and realized that general surgeons take out your appendix and never see you again. Yep. And ENTs have relationships with patients for their careers where they follow the patient, their children, et cetera, because of allergies and sinus problems, et cetera. And I have patients who have followed me from the first, year that I was in practice.
Wow.
And even though I've changed cities, they still find me. So that's what I really like about my career. I always wanted to do something with my hands, and I wanted to have relationships with patients, and I get that.
It's interesting. I would assume maybe the ortho world a little bit with chronic knee pain patients or shoulder pain patients. They may be coming back all the time. But you hope that as an orthopod, you can kind of fix that after a while and the patient goes away. But you can't really fix allergies for the most part. Unfortunately, they're just there.
You can try with immunotherapy, but for the most part, you're right. They're just there.
Yeah. And so that's interesting. So you get a little of the primary care aspect of the longitudinal care of a patient around a certain pathophysiology, allergies in this case, or some other things.
That's right.
While also still getting that hands-on technician, mechanic kind of operator kind of person.
Exactly.
Yes. So both best of both worlds, which is awesome. And again, that's why I love doing these series, because there are students out there who are like, well, I'm stuck between two different fields because I do want that longitudinal care, but I also want to be in an operating room. And there aren't a lot of surgical subspecialties that will give you that opportunity for both. So
really
ENT
true.
Is one of them. What's the worst part about it? What do you like the least? Besides charting, besides insurance, besides the knowns.
Charting is not, I've never found charting to be a problem since we've had electronic medical records, because I type rather quickly and I create templates and things. And I do my charting in the room with the patient. So when the last patient leaves, I'm ready to go unless there's some other issue. So I highly recommend that. Come up with a system that works for you so that you're not stuck at the end of the day with 2 hours of charting. I think that is a way to not have burnout.
Definitely.
But I would say what I like least is just being called at 3 a.m. for call. That's as a surgical subspecialist, you have to have privileges at a hospital. And the corollary of that is you take call for that hospital, with a few exceptions, I'm sure. But I actually took call continuously from the time I was, a resident until this year. I'm off the call schedule, after a lot of years. So, but that's true. Everybody takes call at some point. So
what is a reason for a 3 a.m. wake up call and going into the hospital?
Foreign bodies are a big one, especially pediatric foreign bodies. Kids like
those darn Lego bricks.
What's that?
Those darn Lego bricks.
Yes, exactly.
Yeah.
Yeah. And nosebleeds.
Mm.
And then the occasional person that comes in the middle of the night that's smoked for 132 years and finally at 2 a.m. can't breathe anymore.
just randomly.
Just randomly.
Just
Exactly.
randomly. Yeah, interesting. Okay, so there are some midnight emergencies where you're called in. Is that a situation?
Not as many as other fields, but
Yeah.
yes, there are.
Yeah.
There are.
Is that a situation where emergency medicine physicians are potentially trained to do what you're being called in to do, but they can't get it, or maybe it's too far in and that's past their scope of practice? What's the line between them going and just getting it versus needing you?
My experience is, and obviously I'm not an emergency room physician, but my experience is that they generally don't try to get it if it's a stable patient. The emergency room physician will do what they have to do if the patient is, needing care right now, because it's going to take me 20 minutes to get there. But if they call me and I can get there, then they leave it for me so that they don't, the last thing you want to do, first, do no harm. The
Yep.
last thing you want to do is take a stable patient with a foreign body and make them into an unstable patient when you're not in the operating room.
Yeah.
So usually they won't try to tackle that. They'll let me do it.
Yeah. Like, oops,
I wish they
pushed
would
it down further.
I saw a question on the screen about scribes.
Scribes.
And
Yeah.
I don't have any experience with that. I've always typed. I think scribes definitely can make your life easier, but there is a cost to it. You're paying the scribe. So if you can do it yourself in some fashion, I think you're saving money, but you have to, weigh the lifestyle of doing it yourself or paying somebody else to do it.
Yeah. Yeah. I think it's a very personal decision, and I think very specialty driven, depending on how long typical notes are, right? My wife being a neurologist notes are notoriously atrociously long, and she has a medical assistant who scribes for her, and she's still charting for hours at night, unfortunately. And she does a lot of medical legal work, and so her notes have to be pristine to hold up in the court of law. So it's hard. It's definitely a balance, and I agree with you wholeheartedly. Finding that ability to I'm a huge process improvement person, and I remember telling my wife at some point when she was charting forever, I'm like, it's okay, like you'll find workarounds and templates and different pieces of software that you can type out a short little snippet code and it'll type out a whole paragraph because you say the same freaking thing every time for a very standard diagnosis. And she loves a lot of my workarounds now for those types of things, because I'm a huge tech nerd. I'm like, we can solve for that with technology.
You bring up a really good point,
Yeah.
because satisfaction amongst physicians, I mean, we're here to help people, but job satisfaction depends on a lot of things, and I think that difficulty of navigating the system, whatever that means, is really important. And so I think scribes can be helpful. For example, templates can be helpful. I mean, whatever you work out for yourself, you're going to be happier if you spend a few hours today to save tens and hundreds of hours later.
Yeah, and it's funny. I've said for a long time, again, I'm a huge technology person. I run a software company now. I've said for a long time with where we're going with technology, that every exam room should have microphones, and the computer should be listening to the exam, and the physician may need to do a couple keywords for, like, okay, I'm examining this part of the body now, and like range of motion, 35 degrees, whatever. And the machine learning and AI and the computer can just put it all in the system. And I've actually started to see Facebook advertising for just that. It's like called Deep Scribe or something, where it's AI driven scribes that plug right into like a handful of different EMRs. I'm like, we're getting there. It's coming.
Absolutely. And there's a lot of protocol driven protocols that we're going to have to follow for various
Yep.
diagnoses. And that's how we're, in the ACO world, for example, the accountable care organization world, you're judged based on the complexity of the patients you see and how well you adhere to the guidelines.
Yeah.
And that's how you get paid. So there's a lot of AI, so to speak, involved in that.
Yeah. Yeah. I'm excited for that future, so that it was a couple weeks ago, we had someone on, another physician on, and just talking about sometimes those protocols are not followed and it harms the patient. I'm like, why can't that be built into the EMR? As soon as one diagnosis comes, like, here's everything you need to do based on this one diagnosis, and it's not there yet, unfortunately.
It is in a certain, small number of diagnoses, but
Yeah.
yes, it is not there yet for the vast majority, for sure.
Yeah. Yeah. So when you look at your path, you found ENT. It has this longitudinal patient care. Training wise, very similar to general surgery. Talk about that training path. It's obviously 4 years of medical school, and then I think 4 or 5 years of ENT residency.
5 years. Some programs are 6. Mine was 5, and it was 1 year of general surgery internship. I was at Henry Ford Hospital in Detroit.
Yep.
And so when I matched in ENT, I was automatically assigned the first year in general surgery there, and then 4 years of ENT. The programs that are an additional year generally have either a research year or require 2 years of general surgery. So I was in a traditional 5-year program, and the first 2 years in ENT are junior resident, and then the last 2 are senior resident, so that you're basically 2 levels. And it was a great experience. I mean, I learned so much. It was phenomenal.
Yeah. I'm not sure. Do you have any cases to go over with us today, or no? Are we just talking?
I didn't bring any specific cases, but I'm happy to, I'm sure I can talk about anything that people want, or
drum one up. Yeah. Well, let's maybe do one in a little bit. We'll let maybe a student come on, or a couple students come on, and try to.
I will tell you that I'm very
questions.
procedure oriented.
Yeah.
I do. I do a lot of surgeries. I do most of them in the office. I have 2 nurse practitioners whom I work with, and it allows us to see more patients, and then it frees up more of my time to do the procedures. And my nurse practitioners are wonderful, and I would not want to work without them. I have to tell you, physician extenders, you find good ones, they're fantastic.
Yeah. There's a lot of stuff in the news here in Colorado, where I am. The AMA, I think, just defeated PAs trying to become independent. There's a lot of fighting amongst everyone, but at the end of the day, they serve an amazing purpose. And there are some that want more, and we'll listen, maybe.
Yes.
Yeah. So looking at your path, you do a lot of surgeries. Obviously, surgical skills are needed, hand-eye coordination, manual dexterity, all of that fun stuff. For someone listening who's like, I really want to do that, and I have thumbs for fingers, is that something that can be learned, or you either have it or you don't, do you think?
So I guess my answer would be based on my residency experience, where there were a number of residents of different years, ahead, behind me, et cetera. Everyone got through it just fine. There wasn't anyone that didn't. People had various levels of skills, just like people had various levels of knowledge on the in-service exam and things like that. So I would say that it's something that you can learn. If it's something that you want to do, don't be discouraged. Go ahead and do it, because you will be able to.
Yeah. I'm a little disappointed they don't the stereotypical, like, sew together a couple slices of cheese part of the residency interviews, that can't do those things anymore. But yeah, I think
I tied knots on chairs during my general surgery internship year, the entire year. I would buy rolls of thread, and I would just tie knots, and I would do one-handed and two-handed. And, that was It was fun. It
Yeah.
just was what I was doing in my spare time.
Yeah. My scrub pants always had thread hanging off of it so I could
Yes.
tie knots. I think every surgeon, every proceduralist that I've talked to has said these are skills you can learn. You do them over and over and over and over again, and you learn them. Looking at the training path, looking at your career now as an ENT, do you feel like your specialty and what you've taken on in terms of your practice, does that afford, and I hate the term work-life balance, but does that afford, at least for you, the life that you want in and out of clinic and the hospital setting?
The answer is it's whatever you make of it. It's similar to the question that was asked about a scribe or that sort of thing. It's whatever you want it to be, and you can work long hours or you can work not as long. For the first 10 years of my career, I took Thursday afternoons off. That was just what I did, because I joined a group initially where everybody had an afternoon off and they assigned me Thursday. So, it allowed me to go and do the things I needed to do outside of work, and it made a huge difference. And then I stopped doing that. I joined this multi-specialty group, and it wasn't a thing, not that they told me one way or the other. I was busy and I didn't do it. And now I'm taking Friday afternoons off just recently. And it's whatever I think you can make it whatever you want. You can make your hours long or short. And I think, again, you have to look at your individual situation, maybe get help from your peers, from people in your group, if you're in a group, which I recommend. And you can make it great for your situation.
Yeah.
I wouldn't choose or not choose because of a fear of that. I'll put it that way.
Yeah. I think it's a wonderful discussion that I don't think enough people are intentional enough about their life and what they want their life to look like, especially physicians coming out of training. And maybe it's just the system that we're in, coming out of training with $200,000, $300,000, $400,000 worth of debt that grows a ton during residency. And so they're making decisions based on the debt versus potentially thinking, what do I want for my life? Do I want to work 5 days a week, 4 days a week, 3 days a week? What does that look like? And let me go find a practice, a setting that will allow me to do what I want to do.
Well, as an aside, I had debt when I graduated from medical school, and I did many of you have probably heard the Live Like a Resident, and I did that, and aggressively paid off my debt, and that was what worked for me, and I recommend that, and it allowed me freedom, after that. I would say that as time goes on, the world changes and what's expected of you changes, and meaning managed care changes, and the word comes down from from on high, saying, okay, this year we're going to be paid based on the time you spend with the patient. And they did that a couple of years ago. So now you had to document how much time, and you had to look at, and then they said, okay, we're not going to do that anymore, because that is penalizing people who provide good care but don't spend a lot of time, for example. And what we really want is, to pay for good care. So we're looking at that. And so you have to, no matter what field you choose, you're going to have to change with the times. And you're going to have to be constantly educating yourself, not only on your field, but on the business of medicine, so to speak, which is a big reason why I feel like a group is a good place to be, because you have people that are in the same boat as you, in the same group, that are, all collaborating to make changes based on the changing landscape of medicine. On a different subject, but and that is, say, personal satisfaction. I said earlier, I like nasal and sinus procedures. That's what I've always liked doing. And so I've changed over the years my practice um, to bring those kinds of patients in. I have a website that's been very helpful to bring, patients in, and I share some of my experiences on there. And my nurse practitioners see a lot of the patients that are not nasal and sinus patients. They're trained to evaluate, say, the ear patients. And these are things I've done in my practice to make it more of what I want. And I think that they don't teach you these things in medical school, but there are ways you can advocate for yourself to make your career specifically what you would like it to be. And I'm fortunate enough that I've been able to do that.
Yeah, it's one of the silver linings, I think, of social media, is teaching all of these future physicians coming up to be a personality on social media, because you're marketing yourself all the time. And so getting comfortable, if you are comfortable, getting comfortable with creating a TikTok account or Instagram and talking about the procedures that you like to do, that will attract the patients that you want to be seeing. And so it's a fun thing that I think there are some goods to social media, especially for future physicians to go out and market themselves and drum up business, because unlike Field of Dreams, if you build it, he will come. Like that is not the case.
Right.
You got to get those patients coming to you, and lots of networking with physicians. Why don't you talk about that? Right, you have a big group practice there. How much of your time do you spend, or maybe not a lot less these days, going out to primary care physicians and talking to them and saying, hey, we're here for your patients, and here's who we like to see, and here's why you should send them to us? How much of that do you do?
So I have done that at different times, introduced myself to, say, new physicians in our group. We have 350 providers, by the way, in our group. Just
wow.
We're kind of a 600-pound gorilla, and we're privately owned. We're not hospital owned, at this time, that sort of thing. But there's various ways to collaborate with the other physicians, say, in our group. We have monthly meetings. We have, and a lot of those are online. We have various committees, and I'm involved in those things. And we have parties a couple of times a year, that sort of thing. So there's ways that we collaborate. And over the years, I've been in this group since 2008. I know many of the physicians in the and PAs and nurse practitioners in the group. And, once you share a few patients with these people, you kind of get to know who they are. And we have I don't know if are you familiar with Doc Halo? We use Doc Halo. It's a secure text messaging system that our group uses, so we can text on it freely and talk about patients, and it's HIPAA compliant. Somebody will say, hey, I'm going to send John Jones to you. Just want you to know, I've known him a long time. He's going to sound kind of funny, but he really does have a real problem here. So listen, that kind of thing.
Yeah. Interesting. Okay. So lots of collaboration going on. Chris asked a question. Have there been any difficult cases lately? What's been a difficult case for you lately, or just in general?
For me, 95% of the patients have the same anatomy, but 5% of them, I get in and their anatomy is a little bit different. And so I've developed techniques over the years to get the procedure done despite that. It becomes a little bit trickier because I'm dealing, for the most part, in the office with awake patients. Yeah. So I've given them some pre-medication, but they're not asleep. They're talking to me during the procedure. And so not only do I have to navigate their anatomy, but I have to do it with a smile on my face, because they're looking at me the same way you are. And if I have a look of concern, they're going to notice that. No uh-oh faces. Yeah. Right. Exactly. They said it's okay to say shit, but it's not okay to say uh-oh in surgery.
Yeah, I'm assuming you have some code words or looks to your staff of like, I need help without warning the patient.
Right.
What would be abnormal anatomy, like turbinates that are wrong or entries into sinuses that aren't where they should be?
Yes, yes. So entry into sinuses is a big one that where the bone's really hard. And when I'm doing, I do a lot of balloon sinus surgery, which has been, this has really been a revolutionary procedure in ENT is the balloon. The success rate is very similar to traditional endoscopic sinus surgery, but the simplicity and the complications are just far superior, much more simple and less opportunity for complications in the right hands with it. So the balloon is only as good as the person operating it. And in many cases, it's hard to get into these sinuses. So over the years, I've learned to have the instruments ready where I can do a little bit of the traditional procedure, take away some of the bone that's in the way of the balloon, and get a very high success rate. When the balloon first came out, they were reporting 90%-ish success rate at getting into the sinuses. And I experienced that too, where, about 1 in 10-ish, you just didn't get the balloon in and you said, hey, I did my best and I didn't get there. And now with these techniques, I'm getting in there virtually 100% of the time. And, the patients are the same. It's coming up with kind of hybrid surgery. And I'm certainly not alone in doing this. But it's improved the success rate dramatically in the office with awake patients.
Yeah. Here's an interesting question, or maybe it's not interesting. A lot of physicians that I talk to, especially some of these subspecialties, there are becoming more and more turf wars in terms of who does the procedure. Is it vascular or interventional radiology? Have the interventional radiologists come for ENT for some of these procedures?
It's funny. A good friend of mine is an interventional radiologist, and he loves to say, every study shows that interventional radiology does better at everything than everyone else.
Yep.
And he loves to say that.
I've heard it.
Right. And I'm sure that that's true. I haven't really seen that as an issue in my field. I mean, the interventional radiologists, we use them. We've used them through the years for nosebleeds to take out the external carotid system to the nose, and it's worked very well, and it's saved us from doing surgery. As many surgeries as I do, I'm a minimalist, and I don't do far more procedures than I do. And I think that the simplest is the best. And if you don't have to do a procedure, don't do it. And, for every 10 patients that come to me thinking they're going to get a sinus procedure or whatever, maybe one actually gets one. And I think that's really important. You don't want to be a hammer where everything looks like a nail. Because most people do not need surgery. And most people that come in thinking they need surgery do not need surgery. So I would say that, specifically with interventional radiology, if there's a way to do it with that, I'm all for it because it is simpler and the success rate is very high. But, the things that I do, there really isn't another option. The balloon procedure, for example, for sinusitis is the simplest thing available for that. And turbinate reduction is tried and true and long-standing, and it's very simple to do it with minimal complication risk. So I don't find that there's a turf war going on in my specialty.
So it's interesting. It's a common question that I ask is what percentage of patients are you actually doing procedures on? So you're saying very few, 10% maybe, you're actually doing procedures on. Is that because most of the other people just aren't optimized medically, and so it's like you have a long ways to go before you're having a procedure?
So, and let me just clarify, that 10% is people coming in thinking that they've found me and, they're looking for surgery. I have a lot of people that come in that that, you know, are here because they have a, you know, an earache. Well, those aren't people that are coming in for surgery.
Yeah.
But it's because most people have not been maximally treated medically, and they'll do better when they are, or what they think they have is not what they have. Allergies and sinusitis are not distinguished in the general population. And I don't know why, but it seems to me that by default, people think they have sinusitis. And you ask for the history and they go over the actual definition of allergies, and they say, yes, I have sinus problems, but they're describing allergies.
Yeah.
And it's interesting. I'm thinking about it. I just had this happen a couple times today. Patients will come in and I'll say, you know, so tell me about your, you know, I'll introduce myself and say, tell me about your, you know, your situation with your sinuses. Well, I'm having chronic sinus problems. You know, I get sinusitis 5 times a year, and I've been treated with Augmentin, you know, every 2 months. And I was treated with a Z-Pak last month. And I stop and I go, okay, what are your symptoms? Well, I get sinusitis. I'm like, okay, without using sinusitis, what exactly is it that you're getting? And I realized that they go to their doctor and they say, I have another sinus infection. The doctor writes a prescription, and there's really no thought process going into it. Well, those people have allergies by and large, or you know, non-allergic rhinitis, vasomotor rhinitis, and they're being treated as if they have infections. And when I say to them, so you've been on antibiotics? Oh, I've been on antibiotics, you know, 83 times. They haven't helped you, right? That's right. That's why I'm here looking for a balloon procedure. And I say, well, maybe you don't have sinusitis, and that's why the antibiotics aren't working.
No, doc.
And they kind of look at me saying, what?
Yeah. Oh, man.
And that's why I operate on, you know, 10% of those people and not a higher percentage.
Yeah. Interesting. The only thing that I remember from my primary care days was someone complaining of sinus pain, and their teeth would hurt, and I'm like, oh yeah, you do have some sinus infection going on.
That's a very good sign of that. Yeah, I mean, it's not 100%, but that's a very good sign that they are going to have some sinus disease for sure.
Yeah, that's interesting. So let's maybe bring on some students who have some questions. If you want to ask a question, go ahead and raise your hand. We'll bring you on, allow you to ask a question. What's before we jump into the first student coming on, just biggest piece of advice for someone who's interested in ENT at this point?
I would tell you that it's a great field because it offers so many options for you to be more surgical, less surgical, pediatrics, adults, to follow people for a long time. You know, if you choose otology, you know, ear surgery, for example, you get the opportunity to really do some brain surgery. Essentially, you're working in the cerebellopontine angle, you're working with microscopes. I mean, it allows you so many options of things that you can do, that it's a great field, and it was a great decision on my part, I think, to choose it. It was everything I hoped it would be. It has been.
Yeah, we had an awesome guest on. I forget if it was eShadowing or the other series that I used to do called Specialty Stories, a great neuro-otologist talking about all of the implants and cochlear implants and stuff that he would do for patients. It's amazing the impact that you all can have on patients. So that's great. Nobody's raising their hand. Come on. I know you all have wonderful questions. Don't be shy. Who's going to be the first one? Victoria is going to be the first one. All right.
Hi, I'm Victoria. Can you guys hear me?
Yes.
Yep.
Hi, Victoria.
Hi. So I posted it in the chat. I'm actually, when you talked about the balloon sinus, it's a dilation.
Yes.
So I've looked up multiple videos on it. Well, so I'm watching them at the same time as I'm listening to y'all talk. And I think it was the maxillary sinuses, that the videos that I'm seeing here.
Mm-hmm.
Are you using local anesthetic in those areas, or is it actually able to just go into the sinus through that space?
So we are using local anesthetic. And first of all, the balloon is 6 by 16 millimeters. Okay.
Right.
And we inflate it to 12 atmospheres of pressure. So it's really hard as a rock, but it's not very big. And it's a bendable device on a wire. So you bend it for the various sinuses. We balloon the frontal, the maxillary, and the sphenoid sinuses. The ethmoid you can't balloon.
Right.
So what we do in my office is we give patients a cocktail of medications ahead of time. We use Valium, Phenergan, and Percocet, and they take a pill of each of those about an hour ahead of time. And when they come in, we spray them with topical Afrin and xylocaine, and then we use pledgets with tetracaine for 15 minutes. And so we put those in and just let them sit there. After that, I inject lidocaine with epinephrine, and then I do the procedure. And most patients are happy talking to me, and I get more of, gee, you're done already, than people saying that was miserable, I'll never do that again. But obviously there's some of each, because every patient is different.
Of course, yeah. Like I was looking, I'm like, wow, they're really talkative and chatty right before this is happening. And the video I just watched, they took it out and he's like, yeah, okay, yeah, that's whatever is going on. They're communicating right after. I'm like, wait, what type of situation are you that communicative right after having something like placed up into your what looks, like it's going like up in the top jaw, or that like it looks like they're just going right in above the teeth there. So
yeah, in the nose, that's the upper jaw is where the base of the maxillary sinus is. But the ostium where we're going in is a little bit higher than that. It's behind the middle turbinate, a little bit higher.
Oh, okay. Okay. All right. Well, thank you very much. I appreciate chatting with you.
Thanks for listening.
Cool. Who else has questions? So you said that there's a small percentage of variance with the anatomy. Is it relatively standard? Everyone's kind of entry points are where they should be? By
and large, yes, but everybody's a little bit different. But everyone has a scan ahead of time. So most of the patients whose anatomy is different, I identify that ahead of time, and I'm prepared for it. But you still have to do the work.
Yeah. And those entry points can be seen on those scans?
Yes, for the most part.
Cool.
Yes.
Okay. Diana.
Hi there. Nice to meet you, Dr. Meyerson. Thank you for having this session, Dr. Gray. I'm wondering how often, I know you commented earlier on talking to the PCPs, but how often are you receiving referrals from these primary care physicians?
Good question. Thanks for listening. Every day. I see approximately 10 new patients a day when I'm in the office, when I'm on my non-procedure days. I actually see a few patients before I do my procedures also. But Monday, Wednesday, and Friday, I see patients. I see about 10 new patients a day. And I would say 80% are referred, and 20% found me some other way, either from the internet or a family member or something like that. And also my nurse practitioners are seeing patients as well.
Oh, okay. Thank you. Thank you very much. And thank you also for this, because I do not have an expansive knowledge on the specialty. And as someone who will, I'm going to be open to the possibilities of medicine. I can't wait. And thank you for shedding light on your specialty. Thank you so much.
Thank you. Thank you.
You're welcome.
Awesome. All right. Couple more. Keep them coming. We'll get you on. Don't be scared. It's okay. We don't bite. And if you want Dr. Meyerson to put on his N95, you feel safer, we'll do that too.
There you go.
If you don't have virus protection on your computer, we'll put some masks
That's it.
on.
Put the N95 on the computer.
Yes, that will work. That would be a wonderful name for a computer virus software. N95, I think, would be phenomenal.
Number one seller, first year in, right?
It would be, yes. Although, yes, Fauci will tell you don't need it, at least for a little bit.
That's it. Excellent.
All right. Well, no questions coming in. We can wrap up a little bit early. Anthony jumping in at the last minute to come in, ask a question, and save us. Hello, Anthony.
Hello, how you guys doing today?
Wonderful.
Hi, Anthony.
My question was more along the lines of lifestyle. I jumped in a little late, so I'm sorry if you haven't already covered it. But yeah, what's the lifestyle like? Do you still have time for like hobbies outside of work and things like that?
Absolutely. It's what you make it. And I mentioned earlier that even early in my career, I was in a group where everyone took an afternoon, a week off, and I had Thursday afternoons off. So it gave me time to, finish at 12 or 1 o'clock. And I'm taking Friday afternoons off now. It's allowed me to tailor my schedule for whatever works. I have children and they're grown now, but I think it's very conducive to a good lifestyle for sure.
Do you work weekends as well? Like,
I
or are
don't
you on
work
call or anything
weekends.
like that?
When I would take call, I'd be on call, 1 out of 3, 1 out of 4, 1 out of 5. It depends on how many people were on the schedule at the time. But that call wasn't in the hospital. It was away from the hospital. And most hospitals have about a 30-minute window where they allow you to come in. So as long as you're within 30 minutes of the hospital, you can pretty much do what you want. So, and for ENT, obviously it's hospital dependent, but the number of times you're called in isn't a lot. If you're taking a week of call, you might have 3 or 4 consults during the week, most of which, or potentially all of which, you can just come in and see them at your leisure because they're not emergent.
Very cool. Okay, awesome. Thank you so much.
You're welcome. Thanks for listening.
Good questions. Victoria says, great website for your practice, theballoondoc.com. Love the name. As someone who has way too many websites, that is a great domain
We've worked
name.
really hard on that. We've worked really hard on that. And I say we, my office manager, and then we have somebody that's created the website. And that's one of the things when I was talking earlier about the things you can do specifically for your, for your likes and your lifestyle, is I've always liked doing nasal and sinus surgery, from the very beginning. And I've how can I do more of that and less of the other things? Because it's what I enjoy. One way is have 2 nurse practitioners, and they see the majority of the patients that aren't nasal and sinus, and I see the ones that I have to. And another way is, sorry, I'm reading God Bless Both. Thank you. Thank you very much. Another way is creating the website to attract people that are looking specifically for that, by advertising and showing the experience that I've had, in that. And it's, it's been very helpful as well. So those are just, as being a tech person, that's one of the ways that you can direct the patients that you're looking for to your practice.
Yeah. Yep. You've done a great job. Dr. Lance Meyerson, thank you for taking some time out of your busy schedule to help educate, hopefully, a few future ENTs here watching and listening today.
It's been a real pleasure. Thank you so much. I appreciate the opportunity, and good luck to everyone watching.
Thank you, everyone, for coming and hanging out. We'll see you next time. Bye-bye.